Welcome to the deep dive. We're here to take complex source material and, well, make it immediately useful for you. Today we're tackling a really important topic, antiepileptic drugs, or AEDs. We're grounding our discussion in Chapter 15 of Lilley's Pharmacology for Canadian Healthcare Practice. Our goal: to get beyond just definitions, we want to really understand how seizure disorders are managed. We'll link the why, the pathophysiology, to the how, the drugs themselves, and crucially, cover those vital nursing implications so you feel prepared.
Yeah, this is absolutely essential stuff. Epilepsy is, well, it's the most common chronic neurological illness out there. And when we talk seizures, we're really talking about hyperexcitation in the brain, too much electrical noise, essentially, in the cerebral cortex. So pharmacology here is all about trying to quiet that down, stabilize those overactive neurons, and success really hinges on first getting the seizure type right, and second, just constant careful monitoring.
Okay, let's start with the basics, the language. Precision here is key, isn't it? We've got three terms to sort out. First, seizure.
Right. A seizure is that temporary change. Could be motor, could be sensory, caused by that burst of excessive neuronal firing. It's the event itself.
Got it. Then convulsion. That sounds more intense.
It often is. A convulsion is specifically the physical part, the involuntary violent muscle contractions. Think skeletal muscles, face. Not all seizures involve convulsions, but it's that outward sign we often associate with severe seizures.
Okay, seizure the event, convulsion, the physical shaking, and epilepsy.
Epilepsy is the underlying condition. It's the chronic diagnosis characterized by this recurrent pattern of unprovoked seizures. It's that tendency for the brain to just, well, generate seizures over time.
Makes sense. What about the causes? Where do these seizures come from?
Well, the text says something quite striking about half the time. Up to 50%, it's primary or idiopathic.
Meaning, we just don't know.
Exactly. No identifiable cause found. The other half are secondary or symptomatic. These stem from something specific, maybe head trauma, an infection like meningitis, a stroke, a brain tumor, something we can point to. It's also interesting the chapter notes that older adults actually have the highest rate of new onset epilepsy.
Really? Not children?
Well, kids can have febrile seizures triggered by high fever. Those can look scary, but they're usually outgrown and don't necessarily mean the child has epilepsy long term.
Okay, good distinction. Now, let's talk classification. You mentioned getting the type right is crucial for treatment. The ILA system from 2017. How does that break things down?
It's really about where the seizure starts. The two big categories are generalized onset and focal onset.
Generalized? Meaning everywhere at once?
Pretty much. The electrical storms start simultaneously in both hemispheres of the brain. The classic example everyone thinks of is the tonic-clonic seizure.
That's the stiffening, then shaking.
Exactly. Tonic phase is the stiffening, clonic is the rhythmic contraction and relaxation, but there are other generalized types too.
Like absent seizures, you hear about those in kids?
Yes, used to be called petit mal. Super important to spot these. They're often just brief episodes of lost awareness, maybe some eye blinking or staring into space. Very common in childhood and easily missed, but they need specific AEDs.
Okay, so that's generalized. What about focal onset?
Focal means it starts in one specific area, one spot or lobe in just one hemisphere.
And how are those classified further?
Mainly by whether the person maintains awareness. In a simple focal onset seizure, the person remains aware. They might have strange sensations or twitching in one limb, but they know it's happening. Consciousness isn't lost.
Okay. And complex focal onset?
That's where awareness or consciousness is impaired or lost. They might seem confused, dazed, perform repetitive actions, but they aren't fully present. And here's a key point. Focal seizures, maybe up to 40% of them, can actually spread and become secondary generalized tonic-clonic seizures. They start focal, but then take over the whole brain.
Wow, okay. That sounds like it could escalate quickly. Which brings us right to status epilepticus. You said this is a major emergency.
Cannot emphasize this enough. Status epilepticus is life-threatening. The definition is basically continuous seizure activity lasting 5 minutes or more.
5 minutes? That doesn't sound like long.
In seizure terms, it's an eternity. Or it can be recurrent seizures happening back to back without the person regaining consciousness in between. Either way, the clock is ticking.
What's the immediate danger? Is it just the physical exhaustion?
It's way beyond exhaustion. Initially, that intense muscle activity causes a huge surge, tachycardia, hyperglycemia. The body is burning fuel like crazy. But if it continues, the system crashes, you get severe hypotension, the tissues aren't getting enough oxygen, hypoxia, metabolic acidosis builds up, and the end result can be irreversible brain damage or even death.
So the absolute first priority is
Airway, Breathing, circulation, the ABCs. Secure the airway, make sure they're breathing, support circulation, always.
And then the drugs come in. Fast.
Right. Once ABCs are managed, you need IV medication immediately to stop the seizure. Typically, a fast-acting benzodiazepine, like lorazepam, is given first line to break that cycle.
Okay, so we stop the emergency. What about long-term treatment? What's the overall philosophy?
The goal for chronic AED therapy isn't always, surprisingly, zero seizures. It's about achieving the best possible control, maximal reduction in seizures with the fewest side effects. It's a balance. Maintaining a reasonable quality of life is paramount.
And there's a key rule about starting therapy, right? One drug first.
Absolutely. Monotherapy. Start with one AED. The data shows this works for about 70% of patients. You only add a second drug or switch drugs if the first one fails at adequate doses.
Okay, that makes sense. And the biggest warning sign we need to flash here is about stopping these drugs.
Yes, this is critical. AEDs must never be stopped abruptly. Never, ever.
Why is that sudden stop so dangerous?
Think of it like pulling a dam away suddenly. The brain has adapted to the drug's stabilizing effect. If you yank it away, you get this massive rebound hyperexcitability. This can trigger withdrawal seizures, make seizures worse than before, or even provoke status epilepticus, even in someone who was previously well controlled. Adherence is non-negotiable.
Okay, let's get into how these drugs actually work at the cellular level. What are they doing to stop those electrical storms?
It's pretty fascinating, actually. There are sort of three main effects, but they often boil down to managing ions and neurotransmitters. First, many AEDs work by stabilizing the nerve cell membranes. They mess with the movement of ions, sodium, potassium, calcium, magnesium across those membranes.
Making them less likely to fire erratically.
Exactly. They increase the threshold needed to make that neuron fire, essentially making it harder to excite. They can also slow down how fast the nerve impulse travels along the neuron.
So calming the individual neuron. What about stopping the seizure from spreading?
That's the second major strategy. Some AEDs work by boosting the effects of GABA.
GABA. That's the brain's main calm-down signal, right? The inhibitory neurotransmitter.
Precisely. Low GABA levels are linked to seizures, so drugs that enhance GABA activity help put the brakes on, limiting the spread of that seizure discharge from the starting point to neighboring brain areas.
Okay, stabilizing membranes, boosting GABA. Since we're tweaking these delicate electrical and chemical balances, getting the dose just right must be crucial. Which leads to therapeutic drug monitoring, or TDM?
Yes, TDM is absolutely vital for many of the older traditional AEDs. Why? Because they have what's called a narrow therapeutic index, or NTI.
Meaning there's a very small window between an effective dose and a toxic dose.
Exactly. Too low and the seizures aren't controlled. Too high, even slightly, and you get significant toxicity. You can't just manage these based on symptoms. You need regular blood tests to check the drug levels.
The chapter lists 4 key ones needing TDM. Can you remind us which ones and their ranges, just to emphasize how tight these are?
Sure. The big 4 traditional ones are carbamazepine, therapeutic range is usually 4 to 12 milligrams per liter, phenobarbital, 15 to 30, phenytoin, probably the most famous, 10 to 20, and valproic acid, 50 to 100.
So for phenytoin, 9 milligel might not be enough, but 21 milligel is already toxic. That's a tiny margin.
It really is. And if a level comes back outside that range, you have to adjust the dose, maybe hold the dose, consult the prescriber. It's active management.
All right, let's walk through some of the major drug classes, focusing on the key things our listeners need to remember. Starting with the hydantoins, specifically phenytoin. Big one.
Huge one. Phenytoin, brand name Dilantin often, is a first-line choice for tonic-clonic and focal seizures. It's a high-alert drug, NTI as we said, works well but comes with some very specific significant adverse effects.
The ones people really notice.
Definitely gingival hyperplasia. That's overgrowth of the gum tissue. It can be quite pronounced and requires meticulous, almost obsessive dental hygiene.
And the other one, Dilantin facies.
Yes, that's a constellation of facial changes, coarsening of features, sometimes associated with long-term use. Again, these aren't minor things. They affect appearance, adherence.
It really underscores the quality of life balance you mentioned.
Absolutely. And then there's the IV administration of phenytoin. It's notoriously tricky.
Why tricky?
Because the solution is highly alkaline, very irritating to veins. It must be given slowly, no faster than 50 milligrams per minute in adults. It can only be diluted in normal saline, nothing else, and you must use a filter.
And if it leaks out of the vein, infiltrates.
That's a disaster. Because it's so alkaline, it can cause severe tissue damage, necrosis, sloughing. Really nasty.
That sounds dangerous.
Yes,
Is that why phosphenytoin was developed?
exactly. Phosphenytoin is a prodrug. It gets converted to phenytoin in the body, but it's water-soluble, less alkaline, less irritating. You can give it faster, mix it with dextrose. It's much safer for IV use, especially in emergencies like status epilepticus. Still needs monitoring, of course, for things like hypotension, but it avoids those nasty infusion site reactions.
So why is regular phenytoin still used IV sometimes? Cost.
Often cost and just
Perfect.
familiarity, but phosphenytoin is generally preferred when available for IV routes.
Okay. Next class. Barbiturates, mainly phenobarbital. Seems kind of old
Yeah.
school. What's its place now?
Its main advantage is its incredibly long half-life. This means it often only needs to be taken once a day.
That's huge for adherence, I bet.
It really is, especially for patients who struggle with taking meds multiple times a day. The main downside is sedation, especially initially, but patients often develop tolerance to that. It also has a history of use for febrile seizures, though maybe less common now.
Right. Then immunostilbene's carbamazepine. Second most prescribed in Canada, the text says. What's unique here?
The big thing with carbamazepine to Gretel is autoinduction.
Auto. Like self. It induces itself.
Kind of, yeah. It actually stimulates the liver enzymes that break it down. So over the first couple of months of therapy, the drug essentially speeds up its own metabolism.
Meaning the blood levels might drop even if the dose stays the same.
Exactly. Levels can fall, potentially leading to breakthrough seizures if the dose isn't adjusted upwards to compensate. Prescribers need to anticipate this.
And a key interaction for carbamazepine.
Grapefruit. And grapefruit juice. Avoid it completely. It inhibits those same liver enzymes, leading to increased drug levels and potential toxicity.
Good flag. Okay, moving towards some newer or miscellaneous agents. Valproic acid.
Valproic acid, often Dipacin or Epival, is used widely, especially for generalized seizures, but it carries two very serious warnings: hepatotoxicity, liver damage, and pancreatitis. Both can be life-threatening, so monitoring liver function and watching for abdominal pain is crucial.
And a practical tip.
Don't give it with milk, or carbonated drinks can affect absorption or cause irritation. Take with food, usually.
Got it. What about secunamides, like ethosuximide?
That one's very specific. Ethosuximide, Xaritin, is really only indicated for one thing: uncomplicated absence seizures. Doesn't work well for other types.
The specialist drug.
Okay.
And then there's this newer group, lamotrigine, levetiracetam, topiramate. What's the general vibe with these?
Generally, they're often preferred now because they tend to have fewer broad drug interactions compared to the older agents and less need for that intense TDM, although monitoring is still important.
But not risk-free, right. I remember something about lamotrigine.
Yes, lamotrigine Lamictal has a crucial, though rare, risk: a potentially life-threatening skin rash. It can progress to Stevens-Johnson syndrome or toxic epidermal necrolysis.
So any rash on lamotrigine is a red flag.
Absolutely. Immediate stop, immediate report to the prescriber, cannot ignore it.
And topiramate.
Topiramate, Topimex, has a risk of causing acute angle closure glaucoma. So sudden eye pain or vision changes, that's an emergency. It's also interesting how many of these newer agents like gabapentin, Neurontin, and pregabalin, Lyrica, which were developed as AEDs, are now probably used more often for neuropathic pain.
Yeah, that crossover is fascinating. Okay, this all leads perfectly into the nursing process. Assessment is key. What are we looking for before starting these drugs?
You need a solid baseline: full neurological assessment gait, reflexes, vision, mental status. Because these drugs can affect blood cells and organs, you absolutely need baseline labs: CBC, liver function tests, LFTs, kidney function tests, BUN, creatinine.
And looking for specific risks related to the drugs we discussed.
Definitely. Assessing the skin thoroughly for any existing rashes before starting something like lamotrigine. Checking oral health before phenytoin due to the gingival hyperplasia risk. And screening for any history of mood issues or suicidality, particularly before drugs like levetiracetam Keppra, which can sometimes cause neuropsychiatric side effects like irritability or depression.
Okay, baseline set. Now, implementation and teaching, arguably the most critical part for success. What are the non-negotiables?
Consistency is everything. Taking the medication at the exact same time every single day, that's vital for maintaining those steady therapeutic blood levels we talked about.
And how to take them.
Usually with food to minimize GI upset, which is common, and with a good amount of fluid, like a full glass of water, 180, 240 milliliter.
What about forms like extended release? Can patients crush those if they have trouble swallowing?
Absolutely not. Big safety point. Never crush, chew, or open extended relief or sustained release capsules or tablets. That defeats the whole point of the slow release and can dump the entire dose into the system at once, risking toxicity.
Okay, crucial point. What about daily life activities? Driving.
Sedation is a common side effect, especially early on. So patients need to avoid driving, operating heavy machinery, or doing anything requiring high alertness until they know how the drug affects them and their dose is stable.
And interactions. We mentioned grapefruit with carbamazepine. Anything else major?
Oral contraceptives are a big one. Many AEDs, especially the older enzyme-inducing ones like phenytoin, carbamazepine, phenobarbital, can make birth control pills less effective. Women need counseling about using alternative or barrier methods of contraception. Also, general advice to avoid alcohol, excessive caffeine, and smoking, as these can potentially lower the seizure threshold or interact with the medications.
And that universal piece of advice.
Wear a medical alert bracelet or necklace, always. It should state they have epilepsy and list their medications. It speaks for them in an emergency.
Perfect. So wrapping this up, if you had to boil down the key takeaways from this deep dive into Lilley's chapter, what would they be?
Okay, three main pillars, I think. One, accurate diagnosis is paramount. Getting that focal versus generalized onset right dictates the drug choice. Two, TDM isn't optional for those NTI drugs. It's essential for safety and efficacy. Three, patient adherence. Non-adherence is still the #1 reason treatment fails, so education and support are absolutely critical.
That focus on the patient really brings us to a final thought, connecting back to daily life. We know Canadian driving regulations are strict reporting epilepsy, needing usually a 6-month seizure-free period to drive. But it's so important for everyone, especially healthcare providers, to remember the Canadian Human Rights Act. Having epilepsy shouldn't automatically prevent someone from having a successful career or living a full life. Effective drug therapy, when possible, aims to make that a reality. Thank you so much for walking us through all of that. It's complex, but so important.
My pleasure. A warm thank you from the Last Minute Lecture team.